Hello everyone, this is Dr. Chandana Vishwanathan. The topic for today is respiratory system for Mrcp part 1 and part 2. The main focus is on pneumonia. So let's go into the topic. The most important thing in pneumonia is curve 65 score. So all the components, how do you calculate the score and what is the interpretation of the score, everything is important about this scoring system. This is mainly used to grade the severity of the pneumonia, based upon which the patient's mortality is predicted, and based on this score only you decide if the patient needs an admission, or if the patient needs to be kept in an intensive care unit or not. So the components include, the first one is confusion. If the patient is confused, he will be getting 1 point, and if the urea is greater than 7 millimoles per liter, the patient will be getting 1 more point. Respiratory rate greater than 30 per minute or greater, so this will be another point. And systolic blood pressure 90 mmHg or less, or diastolic blood pressure 60 mmHg or less, this will be getting another point. And the patient's age is greater than 65, then other point you have to add. Basically these all are poor prognostic factors which determine the severity. So if any of these are present, the score will be increasing. uh, Increased score will be predicted as increased mortality. For example, a score of 3 is associated with mortality of 17% for community acquired pneumonia, and for 5, this rises to a risk of mortality is 57%. So, as these features keep on adding in the patient, the severity of pneumonia is more and the mortality of pneumonia is more. So obviously, lower scores may be safely managed at home. 0 or 1 may be safely managed at home, and score of 2 should receive hospital care, while high dependency unit or intensive care unit should be considered for score 3 or more. This is just a scoring system which helps us in classifying these patients based on severity, but clinical judgment is also important. Based upon score, you don't have to either admit the patient or not. Your clinical judgment is also important to decide. So these are some of the important things in pneumonia that we need to discuss. The first one is something called as point of care CRP test, which is included in the NICE guidelines, but currently it is not widely used. With reference to the antibiotic therapy, it states that if the point of care CRP is less than 20 grams per liter, we do not offer routine antibiotic therapy. But if the CRP is greater than 100, we need to offer antibiotic therapy. If it is 2200, we need to consider. So if the CRP is 2200, we need to consider a delayed antibiotic therapy. But nowadays this is not widely used anywhere. Based on curve 65 scoring only, we need to grade the severity and we need to admit the patients. And coming to the investigations that are needed in pneumonia, the first one is obviously chest X-ray. We need to do a chest X-ray. And in intermediate or high-risk patients, NICE also recommends blood and sputum cultures, pneumococcal and Legionella urinary antigen tests. And CRP monitoring is also recommended for admitted patients to help to determine the response to treatment. So, chest X-ray, blood and sputum cultures if required, and pneumococcal and Legionella urinary antigen tests, and CRP monitoring. These are the basic investigations that you need to remember, but in MCQs they are not particularly asked. And these two are very important: management of low severity community acquired pneumonia and management of moderate to high severity community acquired pneumonia. So what is the difference? So low severity is the first line would be amoxicillin, and if the patient is allergic, then we can go ahead with the macrolide or tetracycline, and 5 days of course of antibiotics. For patients with low severity community acquired pneumonia is recommended 5 days of antibiotic therapy. So I have came across an MCQ where the patient is having a low severity um, community acquired pneumonia, where the patient needs home management based on curve 65 scoring. There is low severity of pneumonia, and this patient is allergic to penicillins. In the question, it was given as allergic to penicillins is there, penicillin drugs is there. So what would be the next appropriate management option? In the options, they have given doxycycline. So doxycycline would be a good antibiotic if the patient is allergic to penicillin drugs. And coming to the management of moderate to high severity community acquired pneumonia, for these patients, dual antibiotic therapy is recommended. Usually, amoxicillin with macrolide antibiotic is given, and a 7 to 10 day course is recommended. So, sometimes we can also add a beta-lactamase stable penicillin, such as coamoxiclav, where clavulinate acts as an beta-lactamase and it increases the availability of amoxicillin. And piperacillin with tazobactam can also be used. And macrolides are added along with these penicillins. So dual antibiotic therapy should be given. So remember, if the patient, the question states that the patient is having high severity pneumonia, according to CURB 65, and requires a hospital admission in intensive care unit. In that case, what would be the best appropriate management plan? And then they will give some options such as IV amoxicillin with a macrolide, which is clarithromycin or erythromycin. So that dual antibiotic should be given. So that option would be a better one to select. And the next one is discharge criteria and advice post discharge. Usually, NICE recommends patients are not routinely discharged if in the past 24 hours they have had 2 or more of the following features. There are some features which the patient shouldn't have before discharge, like the 24 hours in the past 24 hours. If these features are present, 2 or more of the features are present, discharge is usually not considered. Those features are temperature greater than 37.5, respiratory rate greater than 24, and heart rate over 100, systolic blood pressure over 9, less than 90, and oxygen saturation less than 90 on room air, abnormal mental status, and inability to eat without assistance. So if these features are present, the patient is not considered for discharge. Basically, the vitals need to be stable, and the patient's consciousness and everything. The patient should be able to eat on his own, and there shouldn't be any confusion at the time of discharge. So these are expected in a patient with pneumonia to recover, and then only the discharge is planned. And resolution of features and follow-up. There are some features which resolve over time in pneumonia. So in 1 week, we should expect fever should have resolved if the patient is responding to antibiotic therapy, and the chest pain and sputum production will reduce substantially in 4 weeks, and in 6 weeks the cough and breathlessness will be reduced, and in 3 months most symptoms will have been reduced, but fatigue can be present till 3 months. So very long duration of fatigue can be present, and 6 months, by 6 months patient will be able to feel back normal. So these are some of the resolution and the timing of resolution of symptoms on any patients with pneumonia. You need not remember all those. It's okay. But just remember that the patient completely becomes normal by 6 months. Okay. The next one is expected MCQs on CURB 65 scoring. So they will be asking the components of the score. Like they will be framing the question of pneumonia, and they will be asking which one of the following is a poor prognostic factor, or which one of the following is a component of CURB 65 scoring. So you need to know the exact values, like the respiratory rate or the blood pressure values. All those in the CURB 65 you need to be thorough with the components of the score. And the second thing that they can ask you is score calculation. So there will be a clinical scenario. They will give you the urea values, they will give you the mental status, and they will give you everything, the blood pressure and respiratory rate, everything, and they ask you to calculate the verb score. That is a direct MCQ that can appear in Mrcp part 1. And in Mrcp part 2, they expect you to tell about the admission and the deciding management. You have to calculate the score, you have to decide where to admit, if it is in the medical ward or high dependency unit, or a home management is required. That you need to decide based on the MCQ scenario, or deciding management. So if the patient requires high dependency unit admission, it means the patient pneumonia is very severe. So in that case, dual antibiotic therapy is required. So directly they can ask you what is the appropriate management plan for this patient. So these are the expected MCQs based upon CURB 65 scoring. And the MCQs can also ask you the organism that is causing pneumonia. So the important, I've made this list of important organisms causing pneumonia. The first one is Streptococcus pneumonia, which is the most common cause of community acquired pneumonia. And Staph aureus, Klebsiella, Pseudomonas, Legionella, Mycoplasma, Chlamydia psittaci, Listeria, and tuberculosis. These are all some of the important pneumonia causing organisms. Tuberculosis is very vast, and we can uh, study it later, but these organisms and some of the classical features of these organisms are important because these features are they come in the exam and the question, and they expect you to diagnose the organism. So I'll tell you such features which are very important to diagnose the cause of pneumonia, and these are very frequently expected MCQs. So going to the first MCQ, see, the 42-year-old man who is known to be HIV positive presents with cough, productive rusty colored sputum, which is important, rusty colored sputum, and he has been unwell for around a week or so. An examination is pyrexial with a BP of 135/70, his pulse is 95. A regular auscultation of the chest reveals area of bronchial breathing over the left lower lung field, and in the investigations we can see there is neutrophilia is present, and the other investigations are quite normal. And on just X-ray, they have given that there is left lower lobe consolidation. So this is the left lower lobe consolidation where the diaphragmatic outline is not preserved. The diaphragmatic outline of the left hemidiaphragm is lost. So this is the left lower lobe consolidation. Which of the following types of pneumonia is most likely the diagnosis? So they have given pneumocystis, Staphylococcus aureus, Mycoplasma, Streptococcus pneumonia, and Klebsiella. So I will tell you individually how to diagnose these organisms. But in this case, the patient is having a community acquired pneumonia, and as I told you, Streptococcus pneumonia is a most common cause of community acquired pneumonia, and HIV increases the risk of Streptococcus pneumonia infection. And if there is a particularly if there is a low CD4 count, and the chest X-ray is showing a lobar consolidation, which is again in favor of Streptococcus, and neutrophilia, which is the one which fits best with Streptococcus pneumonia rather than any other cause of respiratory tract infection. So if there is neutrophilia, lobar consolidation in a HIV patient, you can go ahead with Streptococcus pneumonia. Even if there is no HIV, most common cause of community acquired pneumonia is Streptococcus pneumonia only. So these are the points that I've already told you. And coming to Staph aureus, Staph aureus infection usually occurs after a period of influenza. So the patient will be having flu-like symptoms in the question. Initially, for flu-like symptoms will be there, followed by after a few days the patient will develop pneumonia. In this case, we can suspect Staphylococcus aureus infection mainly. That can be an MCQ. And this Staphylococcus aureus can be complicated by formation of lung cavitation, pneumatocysts, pneumothorax, pleural effusions, and empyema. So these are also expected in the question. Lung cavitated lesions can also be there. And coming to Klebsiella, it is caused by Klebsiella pneumonia, is a gram-negative rod that is a part of normal gut flora. And this pneumonia by Klebsiella usually follows aspiration. So in the MCQ, they can give you an stroke patient who is a high risk for aspiration and who has aspirated and developed pneumonia over few days. So in that case, you can suspect Klebsiella, and it will also cause urinary tract infections. And the features of Klebsiella pneumonia, it is more common in alcoholics and diabetics. So in the question, they can also mention that the patient is alcoholic and is a diabetic, and that can happen following aspiration. This is very important. These 3 points, alcoholics, diabetics, and aspiration, is very important. And red colored currant jelly sputum. As I told you, in Streptococcus there was rusty colored sputum, and in Klebsiella there is red currant jelly sputum, and it often affects the upper lobes, and sometimes cavitations, lung abscess, and empyema can be seen as a complications of Klebsiella pneumonia. But upper lobes, aspiration, red currant jelly sputum, alcohol, and diabetes, these 5 points should be there in your mind, and the option should be Klebsiella pneumonia in case these 5 points are there in the question. Not only 5 points, but clinically you have to make a judgment if it's Klebsiella or not based upon these things. Usually in aspiration, the question will be on aspiration. So this is the way you diagnose Klebsiella pneumonia. The mortality is 30 to 50%. And usually Pseudomonas pneumonia questions are not usually asked, but if the patient is a cystic fibrosis patient or a post-renal transplant patient, diabetes, HIV, neutropenia, and burns, until unless the patient is having such a severe immunocompromised state, Pseudomonas is usually not a diagnosis. And it is a very important cause of hospital acquired infections, such as hospital-acquired pneumonia, especially if the patient is immunocompromised host. So in the question they will mention that if the patient is cystic fibrosis patient or a post-renal transplant patient, then you can suspect or consider pseudomonas infection if it is there in the options. And these are two important atypical pneumonias. One is Legionella, the other is organism is Mycoplasma pneumonia. So Legionella pneumophilia and Mycoplasma pneumonia. So there are some common features for these two, which is both are atypical pneumonias with dry cough. This is also atypical pneumonia with dry cough, and both have flu-like symptoms, and both are responsive to macrolides. This is also responsive to macrolides. Uh, and there is this is the differentiating features for specific for Legionella, which is lymphopenia, hyponatremia, and diagnosis by urinary antigen test, and the presence of pleural effusion in 30% of the patients, and there will be lobar or multilobar pneumonia just X-ray. But in these patients, the diagnosis is mainly by serological test, not by urinary antigen. In Mycoplasma, it is serology, and there will be prolonged course. And positive cold agglutination test is also very suggestive of Mycoplasma. There will be bilateral consolidations. So this is the way that you diagnose Legionella versus Mycoplasma. And in Legionella, they will be giving you a clue that the patient recently exposed to water tanks or air conditioner or for holidays. So usually this organism is usually it is there in air conditioning and water tanks. It is inhabitant of these areas. So exposure to these water tanks or air conditioning systems can predispose the patient to Legionella infection, where we treat the patient with macrolides, that is clarithromycin or erythromycin. But if the patient is having severe pneumonia, you can directly go to IV levofloxacin, which is quinolone. IV levofloxacin would be a treatment of choice. Even if the options is having macrolide, go with IV levofloxacin. If the patient is having severe pneumonia, you have to clinically judge if the scenario is having the patient is having a severe pneumonia or not. So they can ask you MCQ in this way, like the patient is having symptoms of atypical pneumonia such as dry cough, flu-like symptoms, and the chest X-ray is showing lobar or multilobar pneumonia, and on investigations there is lymphocytopenia, and the sodium is of low value. Mainly this hyponatremia is due to SIADH, which is associated with Legionella infection. And what would be the next appropriate investigation to do? So in that case, you have to go ahead with urinary antigen test as you suspect Legionella, or they can directly ask you what is the treatment of choice. Then you can opt for an macrolide, which is clarithromycin. And if the patient vitals are not stable and if there is an evidence of severe pneumonia, you can go directly select the option of IV levofloxacin. And if some patients are not responsive to levofloxacin, then the treatment of choice would be meropenem. But in options, look for IV levofloxacin. Only if there is no macrolide, there is no levofloxacin, then only choose the option of meropenem. So this is all about Legionella. And coming to Mycoplasma, these are the features as I already discussed, but there are some other additional features of Mycoplasma that are very important, such as cold agglutinins. As I told you, there is the cold agglutination test is positive, and there are some cold agglutinins, IgM antibodies, which circulate in the blood, and these cause hemolytic anemias and thrombocytopenia. So in the question, you may be having investigations which are showing the thrombocytopenia, which is idiopathic thrombocytopenia, and hemolytic anemia picture can be there in the investigations. And they describe a rash that is associated with pneumonia, like multiform erythemanodosum. So if the rash is described in the question, you can consider Mycoplasma. And some CNS related complications such as meningoencephalitis, GBS, and other immune-mediated neurological diseases can be associated with Mycoplasma. Bullous meningitis, which is painful vesicles on the tympanic membrane. There can be pericarditis, myocarditis, hepatitis, pancreatitis, acute glomerulonephritis. So Mycoplasma can be very much complicated with all these complications. So it is important to diagnose such a condition because it's very much treatable with macrolides. So that's it. That is all about Mycoplasma pneumonia. And in Mycoplasma pneumonia, doxycycline is also very good antibiotic. So if the options has macrolide, you can select macrolide. If the options is having doxycycline, you can select doxycycline. Usually both are not given in the options. So if in case it is given, go ahead with doxycycline. And the other important pneumonia is chlamydia psittaci, which is an other atypical pneumonia along with Legionella and Mycoplasma. The patient will be having fever with history of bird contact. This bird contact is very important, and they present with pneumonia with severe headaches, organomegaly, and failure to respond to penicillin-based antibiotics because it is an atypical pneumonia and it doesn't respond to penicillin-based antibiotics. And it's usually seen in young adults, and the transmission is typically from birds or bird secretions, including urine and feces. And the infection typically occurs after cleaning bird cages. So in the question, carefully look for any evidence of bird exposure, bird contact, or urine or feces exposure to the bird. Like if that is there, you can consider psittacosis. And these patients usually there is subacute onset flu-like symptoms. As I told you, there will be headache, myalgia, and fever. And coming to respiratory symptoms, such as dyspnea, dry cough, and chest pain can be there. On examination of the chest, there will be unilateral crepitations and vesicular breathing. Vascular breathing is commonly there, and there can be evidence of pleural effusions, which is uncommon. As I told you, there can be organomegaly. If the question is having pneumonia with organomegaly, you can consider psittacosis. These are some of the ways in which the MCQs can be framed. There are many MCQs that can be asked from pneumonia. So I am telling few of those MCQs. For example, the patient is having dyspnea, dry cough, chest pain, and on examination there is unilateral crepitations and hepatomegaly, splenomegaly. I know it is rare. It is rare associated with organomegaly, but in case the options is also having psittacosis, please consider psittacosis as an correct answer. The investigations will have raised inflammatory markers and chest X-ray will show consolidation. The confirmation of the diagnosis with serology, usually as a part of atypical pneumonia screening. Serology is the confirmative test. The first line drug would be tetracycline, which is doxycycline, and second is macrolides such as erythromycin. So the question is framed in such a way that there is bird exposure, there is pneumonia, features of pneumonia with hepatomegaly, splenomegaly, and serology is positive for chlamydia psittaci. Then they will ask you the line of management. In that case, you have to choose doxycycline. And another very rare pneumonia is listeria, where the patient will be having history of gastroenteritis or diarrhea, followed by pneumonia in immunocompromised patient. So there can be associated bacteremia, central nervous system infection, meningoencephalitis, ataxia, seizures. It is very rare pneumonia, but just remember that the treatment of choice in this case is amoxicillin and ampicillin, and pregnant women are at high risk for listeria infection. The other one is pneumocystis jirovecii pneumonia, which is pneumocystis carinii, now called as pneumocystis jirovecii, and it is considered as a protozoa, and it is the most common opportunistic infection in AIDS patients. So if the CD4 count is less than 200, the patient should immediately receive pneumocystis carinii pneumonia prophylaxis, which is cotrimoxazole. And the features include dyspnea, dry cough, very few chest signs. The examination can be given as normal. So don't confuse that if there is no pneumonia, there will be pneumonia, but there won't be any chest signs. And pneumothorax is a common complication of PCP. This is also multiple times asked in MCQ, pneumothorax in PCP as a complication. And they will give you a clinical scenario where the patient is HIV positive and CD4 count less than 200, and the patient presented with dyspnea, dry cough, and on chest examination, the patient's chest examination was normal. And then they will give you some extrapulmonary manifestations. They can be given or not in the question, such as hepatosplenomegaly, lymphadenopathy, choroid lesions can be given or not. And they'll give you that this chest X-ray is normal. Then don't confuse that the patient is not having pneumonia. Even if the chest X-ray is normal, the patient can be having PCP pneumonia because the CD4 count is less than 200. You have to consider PCP pneumonia, and sometimes there can be bilateral interstitial pulmonary infiltrates, but there can be other X-ray findings also, such as lobar consolidation. So as I've told you, the chest X-ray can be normal also, completely normal also. And in that case, you need to diagnose the patient with exercise-induced desaturation, which is there will be normal saturations, but after exercise there will be desaturation, which is very likely that the patient is having PCP pneumonia. And sputum examination also sort of fails to show PCP, so we have to do a bronchoalveolar lavage to demonstrate the PCP organism, where there will be silver staining of the cysts of PCP. So bronchoalveolar lavage is needed to diagnose, and exercise-induced desaturation is very important. And even if this is not given directly, they may give you ABG, which is showing hypoxia, but the chest X-ray is normal. It can be given in that way also. So PCP pneumonia, the management will be cotrimoxazole. In severe cases, it is IV pentamidine. They won't be asking you this one, but cotrimoxazole is very important. You have to remember. And aerosolized pentamidine is an alternative treatment which is less effective. And with aerosolized pentamidine, there is a risk of pneumothorax. So if the patient is having a history of pneumothorax or is likely to develop pneumothorax, do not advise aerosolized pentamidine. And if the patient is hypoxic, the PaO2 is less than 9.3. Then you have to add steroids to reduce the risk of respiratory failure by 50% and death by 1/3. So in the question, carefully look for PaO2 if you are suspecting PCP, to add steroids or not in the management. If the question is about management of that patient, then you have to write cotrimoxazole with steroids if the patient's PaO2 is less than 9.3 kilopascals. So be careful with the questions of PCP. So this is one of the table where it is very easy to see. Respiratory syncytial virus causes bronchiolitis, parainfluenza causes croup, rhinovirus causes common cold, influenza causes flu-like symptoms, streptococcus pneumoniae is the most common cause of common pneumonia. All these I have discussed. Just a brief review. Haemophilus influenza is can be a cause of common pneumonia, and most common cause of bronchiectasis exacerbation. This is very important. Bronchiectasis exacerbation. They have asked this question previously, and it also causes acute epiglottitis. And Staphylococcus aureus, I already told you, it causes pneumonia following influenza infection. And Mycoplasma pneumonia, we have dealt it in detail. Legionella also, I have dealt it in detail. Air conditioning systems, dry cough, lymphopenia, deranged lifting, hyponatremia. Hyponatremia is very frequently asked question associated with pneumonia. And pneumocystis jirovecii also I have told you in detail. Exertional dyspnea is characteristic clinical feature of pneumocystis jirovecii. But there will be few chest signs, and the chest X-ray can also be normal. And Mycobacterium tuberculosis is another vast topic that can be discussed separately. It can have a wide range of presentation from asymptomatic to disseminated disease are possible. Cough, night sweats, weight loss can be expected in the question. So you can go ahead with tuberculosis in that case. So yeah, this is all about pneumonia, and my upcoming video will be on pneumothorax, which is also very important. When to put a chest tube, when to aspirate the air. All these the indications of aspiration can be asked as a question. So it is very important topic. Pneumothorax is very important, and pneumonia also is very important. As I told you, there are many ways in which the MCQs can be asked or framed. So yeah, please subscribe to my channel if you're liking my videos, and encourage me to make more such videos which are very useful to crack Mrcp. All these questions I have been gathering from various resources, and I'm putting them together, and it is taking a lot of effort for me. So please subscribe to my channel, like and share my videos. That will be an encouragement to me. Thank you.